Chairman, dear colleagues. I'm fortunate enough to be part of this organized committee under supervision of the incredible professors that have been working with me, or I've been working with over the last few months to present this meeting. My topic today is about TAVI, valve-in-valve, which is actually another milestone in the advance of transcatheter valve therapies. I'll be speaking about why valve-in-valve is important, what is the mechanism of failure of bioprosthetic valves, what are the technique, some tips and tricks, and if we do have some limitations, what are the current evidence and what are the future strategies, the technical innovation that might help us to improve this practice. So why valve-in-valve? We all know that there is the bioprosthetic valve from this data that was published in the Thoracic Cardiovascular Surgical Journal in 2001, that after 10 years of implantation of the bioprosthetic valve in the aortic position, usually the bioprosthetic valves start to degenerate. So there is a growing need for these treatment options for patients with failed bioprosthetic valves. The redo surgery, the operative mortality is higher, and some of these patients are being deferred by surgeons. So having a minimally invasive alternative to the conventional redo surgery might be safer if it proved to be as effective as the redo surgery. In Germany, for example, TAVI has been the standard of care for a large number of patients with degenerated bioprosthetic valves. So there are different mechanisms of bioprosthetic valve failure, whether the natural wear and tear, calcification, pannus formation, sometimes thrombus formation or endocarditis are the cause of the bioprosthetic valve failure. These are types of bioprosthetic valves that are present in the market. We have a huge variety of bioprosthetic valves. Some are stented with a pericardial bovine leaflets, some are stented with porcine leaflets, and some are stentless valves, which are the worst category of valves to do a redo intervention with the TAVI, because the risk of coronary occlusion in these types of valves is really high. We don't have a stent to prevent the prolapse of the bioprosthetic leaflets to protrude into the coronary ostia. Whenever we have a patient with a bioprosthetic valve, we have some important consideration, which is the proper size of the valve we have to use, the TAVI valve I mean, and where should we place the valve exactly. So the correct side and the secured position are two challenging and very important questions that we have to answer before proceeding with TAVI. We have to respect what we call the internal diameter. And the internal diameter is quite different from the label size diameter. For example, when I have a perimount of 21, this doesn't mean that the internal diameter is 21. The internal diameter in this valve will be 18. So every bioprosthetic valve has its own chart that tells you what the internal diameter, what the outer diameter, and what the external diameter, and they are all different from the label size of the valve. What we have to respect while proceeding with TAVI is that we have to respect the internal diameter. So simply we have to know the type and the size of the bioprosthetic valve that has been implanted, and we have to get back to the chart and to check the internal diameter of this particular bioprosthetic valve. If we don't know, sometimes we can go for a CT assessment, but it has its own limitations. The second important point before proceeding with TAVI is what provides the anchor, where we have to place the valve. And the anchor is usually the narrowest diameter, and it is at the level of the sewing ring. This is the narrowest part, and we have to anchor our valve in this below this sewing ring. So if we are implanting a balloon expandable sapien valve, it should go like 20% below the sewing ring. And if we are using a self-expandable Evolut R valve, we have to again go with the inflow below the level of the sewing ring. This is an example of a mosaic bioprosthetic valve, and here is the three landmarks of the three horns of the bioprosthetic valve. If we just imagined where the valve lies, it should lie as illustrated here. And this red marker shows the level of the anchoring ring. So in case we decided to go with a TAVI, we have to go below this line so that the valve would be in a secure position, it doesn't embolize, and it will function properly, as illustrated in these images. This is an example of a patient with a bioprosthetic valve failure. You see here the valve, there is a significant aortic regurgitation, and this patient was treated with an Edwards Sapien XT valve. It's being positioned, and sometimes, usually the common practice, we don't use a TE while doing TAVI cases, but in some challenging valve-in-valve cases, we sometimes need these TE images, and again, the valve was implanted, it's, the aortic regurgitation is gone. This is another case, again, a mosaic valve. Again, this time the patient is having significant aortic stenosis and was treated this time with a self-expandable evolute R valve. I think this was a core valve, the old core valve. It's being positioned. Again, we have to check whether the anchor is, and we have to go with the inflow below the anchor, and we are done. So how to strategize your procedure? Actually, there is a very simple and interesting application which is present on Android and iPhone. It's called VIV, or valve-in-valve application. You have to choose the bioprosthetic valve, and it will tell you, it will show you how this valve would look under fluoroscopy, and you can simply choose the size of the valve you want to that was implanted. It will tell you what is the size of the internal diameter, and you can choose whether you want to go for a Sapien, for example, with a core valve, with a portico, whatever the valve you want to choose. It will tell you the appropriate size of the valve you have to implant, and it will give you real images and fluoroscopic images of how you should implant your valve inside the patient. Every bioprosthetic valve has its own angiographic look, and as you see here, malposition is one of the nightmares in the cath lab, because these valves sometimes might embolize either in the aorta or embolize deeply into the LV, and this is if you did not respect the anchor of this particular bioprosthetic valve. Do we have limitation? Yes. And if we are seeking improvement, we have to tackle the present limitations. The main important limitations is the residual transvalvular gradients. The bioprosthetic valves have their inherited gradients, and usually after implanting a bioprosthetic valve, you can end with a gradient, a mean gradient of 15 to 20, and you are satisfied. If the bioprosthetic valve is small and the patient presents with a patient-prosthesis mismatch or a degenerated bioprosthetic valve, you will have a problem of doing an intervention in a small valve with an inherited gradient. So there are some issues that we can, some procedural tips and tricks that we can use to overcome this limitation. High implantation is one of these things. Using a valve with a supraannular function as evolute R, the beautiful thing with the evolute R that the valve or the leaflets, the functioning leaflets, are present in the middle part of the valve, the middle part of the stent. So the lower part of the stent is anchored in the old valve, and the valve is at a higher position in the wide part. So we end up with a very low gradient after doing a TAVI in a valve-in-valve. And usually we have a very satisfactory effective orifice area with this type of valves. One of the solutions that we discussed yesterday when Mohammed Abdul Wahab from Leipzig showed his beautiful case that was valve in valve, we discussed this issue about fracturing the ring. Sometimes the implanted bioprosthetic valve is too small and there is a residual gradient even after implanting the valve. What we can do is we can go with a non-compliant balloon to fracture the ring to give more space in the annulus, and then you will end with a less gradient, a lower gradient. This was first published by a Swiss group. They underwent this procedure for 10 patients and they had 0 complications. It looks scary, but it works. Some of the technical innovation is this valve from Edwards. It has an expansion zone that allows the valve or the annulus to get bigger in the future in cases we had to a patient prosthesis mismatch or we wanted to implant a second valve that's with a lower gradient. Coronary obstruction is a nightmare in the cath lab. This was one of our very early cases where we had to implant a valve in a sutureless valve, and we ended with, unfortunately, this patient passed away, and from the post-mortem images, the coronary obstruction from the bioprosthetic leaflet was the cause of the coronary obstruction. Using a repositionable valve, whether the Volute R or the Lotus valve, it could be a good option in these patients, especially those patients with low-seated coronary ostia, where we fear or where we have the impression from the pre-TAVI, pre-procedural planning that we might end with a coronary occlusion. Using such valve, whether the Volute R or the Lotus valve, being repositionable, we can deploy the valve and check the coronary if they are patent or not. If we had a problem, we can simply retrieve our valve. I'll need 2 more minutes if you may allow me. Stroke risk is higher in valve compared to TAVI in de novo lesions. Do we need embolic protection with the valve-in-valve? Yesterday they used claret for cerebral protection, but do we have to routinely use these embolic devices in every valve-in-valve intervention? What's pro is that we are dealing with friable tissues, we have frequent debris, we have a repositionable valve, so we might need multiple trials of implantation. Yet we don't have enough clinical evidence, and this will add an extra cost for the already costly procedure. Valve thrombosis is again another issue that is higher with the valve-in-valve compared to TAVI in native leaflets. But again, do we have to give anticoagulation after every valve-in-valve procedure? Again, this is a debatable issue. We are using excessive material, there are areas of stagnant flow, there are higher incidence of thrombosis, but we are dealing with elderly population with a high bleeding risk, and again, we don't have enough evidence. So valve-in-valve for a failing bioprosthesis has evolved to be standardized, safe and effective procedure in experienced hands. There are some residual limitations of the current valves and techniques that can be overcome by specific technical innovations and tailored clinical strategies. Dedicated clinical trials related to adjunctive pharmacotherapy and assessing the valve durability are both warranted and needed. The valve-in-valve is technically demanded and should be reserved for highly experienced centers. It's still an off-label indication. You have to remember this. The heart team is very important during the screening before proceeding with TAVI. A Volute R self-expandable valve may be the preferred in patients with small bioprosthesis. We have some new devices that are dedicated for valve-in-valve. we still need more valves that to be dedicated for this particular intervention, enabling treatment of a small bioprosthesis valve with improved efficacy and safety. In the future, dependent on the expanded clinical data, the valve-in-valve approach may affect the surgical practice. I don't know if we have surgeons on board, but I think this will let them implant more bioprosthetic valves and mechanical valves in the future. And thanks for your attention.